I should have just kept going because I only had one slide left on the sodium glucose cotransport inhibitors. So this is going to be a very short little lecture. But the official action of this drug lowers blood glucose levels by preventing the kidney from reabsorbing glucose that was filtered from the blood into the urine. Side effects are a little bit different. You don't have really the GI side effects that you do with some of these other drugs. It might make you feel like you need to urinate more often as your body tries to get rid of sugar, because water tends to follow sugar too. Now, because bacteria love sugar, people have found that they have an increase in vaginal yeast infections and urinary tract infections because bacteria and yeast just love sugar. So if you have more sugar passing out of that particular part of the body, it's going to attract pathogens. So people have to really watch for signs and symptoms of UTIs and yeast infections. Biggest drug interaction is you're going to have hypoglycemia with insulin. If you've got a person who's taking Lasix, they're going to be losing a lot of fluids, and Farxiga, one of the types of drugs, can really make them lose fluids. So the person can get very dehydrated if they're taking both Farxiga and Lasix. So that's just something to keep in mind, to warn the person to drink plenty of fluids because of the possibility of dehydration. Patient teaching, page 320, and nursing implications, page 319. You want to tell the person, drink plenty of fluids, and tell them to watch out for the signs and symptoms of urinary tract infections. Because they're getting rid of so much fluid, the sugar's leaving and the water's kind of following it, potassium naturally probably wants to come along. And so you need to keep the person's serum potassium monitored. They're like you would with any kind of diuretic. Anything that's washing out more fluids, you want to make sure that their potassium is checked. So they're not getting rid of that as well. Next, we'll move into insulins. A lot of this you know because you've already learned it, but we'll sort of review it. This gives a picture of a cell with an insulin receptor. The insulin kind of unlocks that door and allows those glucose molecules to go in and occupy that cell and provide nutrition. I'll talk basically about insulin before I get into this part of the lecture. We know, we've already said, that insulin lowers blood glucose levels by moving glucose out of the bloodstream where it can cause all kinds of problems, and getting it into the target cells. Insulin has small proteins, and they're going to be just destroyed by both acid and alkaline. They have to have kind of ideal circumstances in the stomach, and the intestines are not those ideal circumstances. So we use insulin to replace whatever insulin our body has stopped producing or our body has stopped responding to. So insulin is going to be used for type 1 diabetics and also for type 2 diabetics who are no longer responding to PO meds. And sometimes you'll see a person taking lots and lots of different PO and sub-Q medications, and it just does not work. Their blood sugar stays high. So in those cases, they really need to replace it with insulin. On page 321, it sort of talks about the criteria for switching someone to insulin. On page 323, you see all the different types of insulins. And there are several categories. We've got a rapid-acting category. We've got fast-acting. We've got intermediate-acting and then long-acting. We also have mixtures of the two. Now, we're not going to really study necessarily specific regimens for treating diabetes because every healthcare provider is going to try different things for different people depending on what their particular needs are. Make sure you read all the safety tips. A person needs to eat within 15 minutes of taking rapid acting insulin. And usually rapid acting insulin is going to be given possibly 4 times a day, before meals and at bedtime. So there needs to be regular meals and a bedtime snack, or else the person's going to have a big blood pressure or blood sugar drop after eating. So generally this is given right before breakfast, right before lunch, right before supper, and then before the person has something to eat at nighttime. Remember that insulin is a high risk drug. It's a high alert med. You can kill somebody by giving them insulin in the wrong way. And so according to JACO, we always check insulins with another nurse. Some insulins can be mixed, but Lantus is not one of them. Lantus is a long-acting insulin that you cannot mix with any other medication. There's also Levemir or Detamir. Both of those are long-acting insulins. They can work anywhere from like 16 to 24 hours. Sometimes people only have to have like 1 dose of a long-acting insulin per day. And so they last for a good long time, but you don't mix them with anything. They're not compatible. On pages 322 and 323, we see all kinds of devices for checking blood sugar, for administering insulin. We've got the insulin syringes and the insulin pens that are becoming more and more popular. Make sure you read over all these types of insulins. The onset, when it starts working, the peak, when it works at its best, and then the duration, how long you can expect it to last. And you can see that we've got everything from rapid acting insulins that only last, 2, 3, 4, 5 hours at the most. Short acting, anywhere from like 5 to 7 or 8. Some of the newer ones that are concentrated might last longer. Intermediate acting is usually 10 to 24 hours. And then the long acting can last 24 hours or longer, depending on what you take. So a doctor might try different protocols with different patients, depending on what the needs are.